Hello and welcome to the topic Erythema Multiforme in the Dermatology module. By the end of this topic, you should be able to define Erythema Multiforme, explain the pathophysiology of Erythema Multiforme, outline the causes of Erythema Multiforme and the classifications, describe clinical manifestations of Erythema Multiforme, outline the investigations done for this condition, discuss the principles of management, and finally discuss the complications and the prognosis. Let's get started. Erythema multiforme is defined as an acute, self-limited type 4 hypersensitivity reaction-mediated recurring skin condition that is associated with certain infections, medications, and other various triggers. The word erythema comes from the Latin term which means redness on the skin. The presence of various stimuli triggers immunological response, thus giving rise to manifestations of erythema multiforme. Epidermis is infiltrated by CD8 T lymphocytes and macrophages, in which subsequently it will release diffusible cytokines. And this will initiate inflammatory reactions that will lead to apoptosis of epithelial cells. Cell-mediated immune reaction that is associated with herpes simplex virus antigen can also initiate immunologic reaction affecting the HSV-expressing keratinocytes. Cytotoxic effector cell in the epidermis induce apoptosis of scattered keratinocytes and lead to satellite cell necrosis. The causes of erythema multiforme are 1. Infections that caused by herpes simplex virus, fungi or bacteria such as borreliosis, cat scratch disease, diphtheria, and hemolytic streptococci. Number 2, drugs such as anticonvulsants, antibiotics, and antituberculous agents. And 3, contact exposure such as ammoniated mercury, budesonide, and capsicum. And 4, physical or mechanical factors such as tattooing, radiotherapy, cold, and exposure to sunlight. Erythema multiforme can be classified into two, which is erythema multiforme minor and erythema multiforme major. Erythema multiforme minor shows a typical target or raised edematous papules distributed acrally. Similarly, erythema multiforme major shows the same typical target or raised edematous papules distributed acrally, but it has additional involvement of one or more mucous membranes. The epidermal detachment involves less than 10% of total body surface area. Now, let's discuss the clinical manifestations of erythema multiforme. During mild prodromal, patients could be asymptomatic or showing mild URTI symptoms such as cough and sore throat. The abrupt onset of a rash usually occurring within 3 days, starting on the extremities symmetrically, with centripetal spreading. Meanwhile, in erythema multiforme major, symptoms complained are moderate fever, general discomfort, cough, sore throat, vomiting, chest pain, and diarrhea. Erythema multiforme may involve other systems. The systemic involvement include oral symptoms like difficulty in eating, drinking, or opening the mouth due to erosions of the oral mucosa. Conjunctival involvement may cause lacrimation, photophobia, burning eyes, or visual impairment. Genital lesions are painful and may result in urinary retention. Patients with genitourinary tract ulceration may experience painful micturition. Shortness of breath or difficulty in breathing may occur due to tracheobronchial epithelial involvement. Signs of erythema multiforme are typical. Initial lesion is a dull red purpuric macule or urticarial plaque that expands slightly to a maximum of 2 cm. Lesions are symmetrical, predominantly on the acral extensor surfaces and spreading centripedally. The periphery gradually changes to become cyanotic or violaceous and forms a typical concentric target lesion. Some lesions appear at areas of previous trauma known as Kobner's phenomenon. Generalized lymphadenopathy also commonly seen in erythema multiforme major. Mild temperature elevation is usually noted and dehydration secondary to open skin wound or poor oral intake due to oral involvement may also happen. The hallmark of erythema multiforme is target lesion with variable mucous membrane involvement. And this picture shows typical target lesions on a patient's forehead. This picture shows typical target lesions on a patient's forehead. Now, let's discuss the investigations of erythema multiforme. The diagnostic procedure of erythema multiforme is skin biopsy. Histopathological assessment of the patient's skin biopsy usually shows lymphocytic infiltrate, along the dermoepidermal junction associated with hydropic changes and dyskeratosis of basal keratinocytes. This picture shows a histopathological finding of skin biopsy from a patient with erythema multiforme. Some other lab tests can be done for patients with suspected erythema multiforme. They are complete blood count, serum electrolytes, liver function tests, herpes simplex virus PCR test, as well as a blood culture and sensitivity. In complete blood counts, patients will have moderate leukocytosis and lymphopenia, and this is possibly secondary to the depletion of CD4 lymphocytes in the body. Mildly elevated liver transaminases levels may be found in patients with hepatic involvement. In erythema multiforme patients, HSV PCR test is commonly positive. Blood cultures and sensitivity can also be done to evaluate infection. So the principle of management of erythema multiforme are mainly treating the symptoms, identifying and treating the causes, as well as stopping the offending agents. For patients who have local skin symptoms, we can provide them with adequate antihistamines, analgesia, and local care such as dressings. Adequate eye care is also important in patients who have eye symptoms. If the herpes simplex virus PCR test is positive, antiviral treatment for HSV is also recommended. There are a few common complications that may occur in patients with erythema multiforme. Patients with oral involvement may be accompanied by difficulty in consuming food and fluid, which will subsequently worsen dehydration. Severe eye complications such as purulent conjunctivitis, anterior uveitis, panophthalmitis, and scarring of the conjunctiva usually occur in 20% of the patients. Some patients also develop patchwork appearance of the skin with hypopigmented regions and potential hypertrophic scarring. Pneumonia is also one of the complications in the cases of lung tissue involvement. The prognosis of erythema multiforme depends on the body surface area detached. The healing duration in erythema multiforme minor is 2 to 3 weeks, whereas 4 to 6 weeks in erythema multiforme major. The mucosal lesions take longer to heal. The healing of the mucocutaneous lesions is without scarring, but with frequent change in skin color or dyschromia. Recurrences are seen in less than 5% of cases, mainly in forms of herpes infection. So in summary, erythema multiforme is an acute self-limiting type 4 hypersensitivity reaction-mediated recurring skin condition that is considered to be associated with certain infections, medications, and other various triggers. Herpes simplex virus is the commonest cause, followed by drugs and infections. URTI-like symptoms is in prodromal state, followed by the acute rash is common complaint one would have in erythema multiforme. Target lesions with variable mucous membrane involvement would be pathognomonic. Skin biopsy as the diagnostic procedure, followed by a full blood count, blood CNS, and herpes simplex virus PCR test is indicated. Finally, medical therapy is the mainstay treatment. We have come to the end of this topic. Thank you.